Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization dedicated to furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I am a dental surgeon. So today we have a case presentation which is all about phlebotomy or venipuncture techniques for dentistry. So, background of phlebotomy. Basically, phlebotomy is the drawing of blood, and this has been practiced for centuries and still is one of the most common invasive procedures in healthcare. Phlebotomy comes from the two Greek words phlebos and tome, which mean veins and incision. Today, phlebotomy is used for the drawing of blood for many purposes. Number one, for diagnosis and monitoring of treatment. Number two, for the removal of blood for transfusion. Number three, for therapeutic purposes, for treatment of conditions like polycythemia and hemochromatosis. And lastly, for what we're interested in, for concentrated growth factors. Blood has many functions for the body. It supplies nutrients to tissues in the form of oxygen and hormones. Number two, it removes end products of metabolism like carbon dioxide and urea. And number three, it provides a defense mechanism in the form of white blood cells and antibodies. And lastly, it prevents blood loss through the actions of the process of coagulation. And this is something which is conducted as a result of the use of platelets and coagulation proteins that are inside the blood. So what is blood composed of? We know that blood is about 45% solid and 55% fluid. So of the 45% or the whole blood containing cells, you have three major components. You have the red blood cells, the white blood cells, and the platelets. The red blood cells are the most numerous. These are the erythrocytes, and these are basically the cells which help carry oxygen and carbon dioxide. Then you have the leukocytes, which are the 5 different types of white blood cells, and these help defend against various forms of infection. And lastly, you have the platelets, which are an important component of blood coagulation. The fluid component, which is the other 55%, also known as plasma, is mostly water, about 92%. There's 7% proteins, and about 1% of the fluid is minerals, vitamins, carbohydrates, hormones, enzymes, and electrolytes. So the coagulation cascade. In vivo, in the body, in an uninjured vessel, normal blood usually remains fluid and does not clot. Upon injury, a series of reactions involving platelets and plasma coagulation factors transform fluid body into a gel clot at the site of injury. In the next slide, we have a diagram of the coagulation cascade. Outside of the body, fleshly drawn blood is fluid, but within minutes will spontaneously clot. And these coagulation reactions are usually triggered by contact with a glass tube or a poor blood drawing technique, as we'll demonstrate in our lecture about phlebotomy. So your basic coagulation reaction is basically clotting factors plus calcium form thrombin. This thrombin, along with fibrinogen, basically combines to form fibrin strands. The fibrin strands will trap red blood cells, white blood cells, and platelets, forming a fibrin clot. Fibrinogen and other clotting factors are used up in the formation of the fibrin clot. And to prevent activation of the coagulation process, anticoagulants are used. So what are anticoagulants? So basically, anticoagulants are chemical substances which prevent the coagulation reaction by basically removing or binding calcium or neutralizing thrombin. The use or non-use of an anticoagulant determines with the type of blood sample which is obtained in the form of either getting whole blood, plasma, or the serum. So when an anticoagulant is used, clotting is prevented. This is irreversible. Mixing the blood with anticoagulant is critical. So if you're going to draw blood into a tube with an anticoagulant, you have to ensure that you completely invert the tube 8 to 10 times to ensure that the blood is mixed with that anticoagulant. If the sample is not centrifuged, you can analyze the whole blood. You must separate centrifuge the sample in order to separate cells from the plasma, and the plasma will contain fibrinogen, which is a clotting protein. So when an anticoagulant is not used, spontaneous clotting occurs, and this is also irreversible. Mixing is not required for this. Fibrinogen is used up during the clotting process to form fibrin strands, which will entrap the cellular elements in the formed clot. The clotted sample must be centrifuged to separate the clot from the liquid portion called the serum, and also the other packed red cells. Serum lacks fibrinogen and several other clotting proteins, and calcium is not depleted from the serum. So the appearance of serum and plasma in a normal world is clear and pale. Abnormally obtained samples will show hemolyzed serum, so this is pink to red, and this indicates red cell destruction. You can also find icteric serum, which is dark orange and yellow, which indicates the presence of bilirubin, perhaps in patients who have hepatic dysfunction, or lipemic, milky, indicating the presence of fat. So all blood collection tubes are evacuated tubes. More or less, when you put these tubes into a hollow bore needle inside a blood vessel, it will automatically fill with blood because of the vacuum inside the tube. The amount of vacuum is pre-measured so that the tube will draw a certain amount of blood. A tube that has lost its vacuum will not fill spontaneously. This occurs either by opening the tube, dropping the tube, or pulling the needle bevel partway out of the skin when drawing the blood. These are used with both systems of drawing blood, in a vacutainer system and a syringe system. So a vacutainer system is a closed system in which the patient's blood goes directly from the vein into the stopper tube without being exposed to air. The syringe method, blood is drawn into the syringe and then transferred into an evacuated tube after collection. There's also different types of collection tube sizes. These range anywhere from 2 to 15 milliliter, and the size sort of depends upon the amount of blood that's needed for the test, the size and condition of the patient's vein, and also the patient's age. Tube stoppers are color-coded to indicate the presence and type of additive or the absence of an additive. The color scheme is fairly universal. Always also check your tubes for expiration date and never use expired tubes. So non-anticoagulated tubes, and it's basically tubes that have nothing in them. We're basically going to talk about the glass red tubes. This is what we're going to use 90% of the time in dentistry for the formation of things like platelet-rich fibrin. I've talked about all the other tubes here. I'm going to leave these on the presentation. You can read about them if you'd like. I'm not going to bore you by going through the details of every single tube. Just remember that there's the glass red tube tops. There's no additive. The glass tube basically acts as activates the clotting sequence, and they're most often used for serology, antibiotic detection, chemistry, therapeutic drug monitoring, and blood bank testing. And you don't need to invert these tubes to mix. There's also plastic red tube tops, which contain the additive silica particles to activate the clotting sequence. We don't usually use these for the formation of platelet-rich fibrin. Also remember, because of the silica particles, you have to invert these tubes 8 to 10 times to ensure a proper mixing of blood with the clot activator. I'm sure at some point in time there will be some studies out there comparing the types of platelet-rich fibrin that you can generate using different types of tubes. For the purposes of this lecture that's recorded and created in 2015, we're advocating the use of the red glass tube top. So the other tops, or the other tubes that you can get the gold tube or the mottled red and gray top tube. You can get the royal blue top tube with a red label. And in terms of tubes that have additives in them, so more often not an anticoagulant, remember that these tubes, if you're going to use them, they have to be inverted 8 to 10 times immediately after a blood draw to thoroughly mix the blood with the anticoagulant to prevent clotting. So you'll have the blue top tube, which is a baby blue top. There's the green top tube, a lavender top tube, and then you have a gray top tube, a fibrin split products tube, FSP or FDP tube, a yellow tube top. This was the type of tube that you used most commonly for the formation of things like platelet-rich plasma. Phlebotomy involves the use of large hollow needles that have been in a blood vessel. The needles can carry a large volume of blood that, in the event of accidental puncture, may be more likely to transmit disease than other sharps to the healthcare provider. Bloodborne organisms that have been transmitted after needle sticks include viruses such as hepatitis B and HIV virus, bacteria such as syphilis, and parasites such as malaria. So in terms of protecting patients, there's a number of things that we have to talk about. So to reduce the risks of adverse effects for patients, healthcare workers undertaking phlebotomy need to be trained in procedures specific to the types of specimen which they collect. Such procedures may include arterial sampling, capillary sampling, blood culture collection, and venous blood draws. Health workers who collect specimens from children and infants will also need special training for the practice of these procedures. Phlebotomists working in settings with more technology may be trained in techniques for plasma and red cell exchange, photophoresis, stem cell collection, and cord blood collection. Health workers may need to collect specimens from indwelling central lines or arterial lines for patients. Training should include techniques that ensure that the specimen collected will be adequate and measures that reduce the risk of contamination, clerical error, infection, and injury. When taking blood, health workers should wear well-fitted, non-sterile gloves and should also carry out hand hygiene before and immediately after each patient procedure, before putting on gloves and removing them. The blood should be taken in a dedicated location that ensures patient comfort and privacy. To remove the risk of environmental contamination with pathogens, counter and work surfaces and chair arms should be cleaned with disinfectant at the start of each shift and when visibly dirty. To prevent infections and other adverse events, health workers should follow the guidelines on patient identification, hand hygiene, use of gloves, skin disinfection, use of appropriate blood sampling devices, and safe transportation of laboratory samples. Patient consent and cooperation are important components of respecting patient rights. A patient information leaflet or poster that explains the procedure in simple terms is always helpful. So what about protecting healthcare workers? Similar to protecting patients, best practices in phlebotomy protect healthcare workers as well as patients. One way to reduce accidental injury and blood exposure among health workers is to use safety engineered devices such as retractable lancets, syringes and needle covers, or retractable needles, and when appropriate, plastic laboratory tubes. In our case, I've already described the rationale for why we use the glass tubes. Another approach is to eliminate two-handed needle recapping and manual device disassembly, and instead dispose of the sharps into a puncture-resistant sharps container, a safety container, immediately after use. The best practice is to discard the needle and syringe or needle and tube holder as a single unit into a sharps container that is clearly visible and within arm's reach. The size of the container should permit disposal of the entire device rather than just the needle. Institutions should conduct surveillance on sharps injuries and accidental exposure to blood so that preventable factors can be identified. Support services should also be available for healthcare workers accidentally exposed to blood. These should include immunization with hepatitis B before assuming duties that include potential exposure to blood and body fluids, and post-exposure prophylaxis for HIV and hepatitis B. All healthcare facilities should display clear instructions for procedures to follow in case of accidental exposure to blood and body fluids. These guidelines also outline the responsibilities of managerial staff, including provision of gloves in multiple sizes, single-use disposable needles, and syringes or lancing devices in sufficient numbers to ensure that each patient has a sterile needle and collection device or equivalent for each blood sampling. Sufficient laboratory sample tubes to prevent reuse and manual washing is also recommended. So best practices in disinfection. The current guideline is health workers should cleanse the skin with a combination of 2% chlorhexidine gluconate in 70% isopropyl alcohol, covering the whole area and ensuring that the skin area is in contact with the disinfectant for at least 30 seconds, and then you should also allow a sufficient amount of time for the area to dry completely. Preparing the patient for the blood draw. So ask the patient if they have a latex allergy. Number 2, bedside manner. Gain the patient's trust and confidence and put the patient at ease. If you look like you're nervous, you can only imagine how the patient's feeling. Always display a professional manner and appearance. Number 3, handling difficult patients. So hospitalization or going to the dentist is usually a stressful time for a patient. A patient may be lonely, scared, fearful, or disagreeable, and may react in a negative manner towards the phlebotomist. You should remain calm and professional and treat the patient in a caring manner under all circumstances. Handling inquiries about testing. Some healthcare facilities or hospitals will allow the phlebotomist to tell the patient the name of the test to be performed. Others prefer all inquiries be directed to the physician or the dentist. You can handle the situation by stating that the doctor has ordered the test as part of the patient's care and that the doctor will be happy to explain the test to him or her if asked. If the patient refuses the blood draw, all patients have the right to refuse. I've had patients refuse a blood draw even for the formation of something like platelet-rich fibrin, which would benefit them in their surgical procedure. Reminding the patient that the test was ordered by the doctor as part of their care will sometimes convince them to cooperate. If not, notify the nurse and he or she may be able to convince the patient to cooperate. You should not badger the patient, but you should also not take the easy way out. If the patient truly refuses, notify the nurse and the doctor and document on the order slip the refusal. Verifying diet restrictions. Most often you will need to verify the NPO status if fasting was required for the test. This is usually required for things like LDL, HDL tests for patient, cholesterol tests. Selection of the venipuncture site. So the antecubital vein location varies slightly from person to person. However, two basic vein distribution arrangements referred to as the H-shaped and the M-shaped patterns are seen most often. The H-shaped pattern is so named because the prominent veins in this pattern, the cephalic median, the median basilic and basilic veins are distributed on the arm in a way that resembles a slanted H. The most prominent veins of the M pattern, the cephalic, the median basilic, and basilica veins, resemble the shape of an M. The H-shaped pattern seen is approximately 70% of the population. Here's a diagram. So in this diagram, you can see all of the blood vessels that we've described. So factors in vein selection. Select the vein carefully. The brachial artery and several major nerves pass through the antecubital area. Accidental artery puncture and nerve injury are risks of venipuncture. Prioritizing veins can minimize the potential for accidental arterial puncture and nerve involvement. Typically, a tourniquet is used to aid in the selection of a vein unless specific tests require that a tourniquet not be used. A tourniquet is not necessary if veins are large and easily palpated. However, if only the basilic vein is visible without a tourniquet, one must be applied so that the availability of safer veins, the median and or the cephalic, can be assessed. Palpation is usually performed using the index finger. The collector's thumb should not be used to palpate because it has a pulse beat. In addition to locating veins, the palpation pressure helps to differentiate veins from arteries, which pulsate, are more elastic, and usually have a thicker wall. If you do get an accidental arterial puncture, if suspected, you get something like a rapidly forming hematoma, rapid filling tube, and bright red blood. Discontinue the venipuncture immediately. Remove the needle and apply direct forceful pressure to the puncture site for a minimum of 5 minutes until active bleeding has ceased. The incident documented according to institutional policy is also recommended. Consult with personnel to determine the suitability of the suspected arterial specimen for testing. If the specimen is acceptable, it must be annotated that the specimen was an arterial specimen. In some cases, different normal reference intervals are assigned to arterial blood. This information must be conveyed to the caregiver through test results comments if you are ordering tests with this blood. Nerve injury. If the patient feels a shooting, electric-like pain, or tingling or numbness proximal or distal to the venipuncture site, terminate the venipuncture and remove the needle immediately. Repeat the venipuncture in another site with a new sterile needle if needed. Document the incident and direct the patient to medical evaluation if indicated. Other venipuncture location considerations. Do not draw blood from areas of extensive scarring. Try to avoid healed burn areas. The tissue is not very elastic. Mastectomy. Usually a physician must be consulted before drawing blood from the side on which a mastectomy was performed because of the potential for complications due to lymphostasis. A hematoma. Specimens collected through a hematoma may cause erroneous test results, so phlebotomy must not be performed on any size hematoma. If another site is not available, the specimen is collected distal to or below the hematoma. Indwelling lines. Hepburn or saline locks and vascular access devices. Fistula. A fistula is usually an artificial shunt connection done by a surgical procedure to fuse a vein and artery together and is used for dialysis only. An arm with a fistula should not be used for drawing blood. The use of a tourniquet may cause complications. Leg and lower extremities. Usually permission from a physician must be secured before drawing blood from a leg. This permission must be done or must be properly documented on the patient's chart. A final option might be a femoral stick by a physician. If you can't get blood from an arm for a patient for the formation of platelet-rich fibrin, there are other products that you can use for a patient, or you have to consider the surgical risk versus the benefit of actually drawing blood and forming platelet-rich fibrin versus using something else. Selecting the site. So locating the vein. Position the arm and apply the tourniquet. The antecubital area is most often accessed for the basilic vein, the median cubital vein, or the cephalic vein. Hand and wrist veins are also acceptable. Use the tip of your index finger on your non-dominant hand to palpate the vein. This helps you determine the size, depth, and direction of the vein. Also helps you develop a sense of touch. Veins have a balance or resilience. Arteries pulsate. Choose a vein that is large and well anchored. Once you have chosen a vein, mentally visualize the location and direction of the vein. I'm going to talk about this in the video. I'm going to mention it again. An old nurse once said to me, "Go for the vessel that you can feel, not for the one that you can see." So B, collection site problems to avoid. Sclerosed and thrombosed veins feel hard and cord-like and lack resiliency. These veins are hard to penetrate, they roll easily, and may not have adequate blood flow to obtain an adequate blood sample. Sites with extensive scarring we've already spoken about. Hematomas, which basically indicates blood leakage into the tissue caused by poor venipuncture technique, bending of the arm after venipuncture, decreased platelets, a bleeding disorder or fragile veins, and edematous areas. The site of a mastectomy, as mentioned before, is also to be avoided. IV lines are also a complication or a complicated area to draw blood from. And finally, indwelling lines are also a complicated area. And once again, you should probably have more extensive skill in phlebotomy, not just an online YouTube video, to access these techniques. So inserting the needle and collecting the blood. Properly anchor the vein. The most common cause of not obtaining blood is properly not anchoring the vein. The vein rolls on you. So number one is grasp the patient's arm with your non-dominant hand, placing your finger under the elbow area. This helps keep the patient from pulling away as the needle enters the vein. Use your thumb to pull the skin taut about 1 to 2 inches below the intended venipuncture site. This anchors the vein and also helps keep it from moving or rolling around upon needle entry. Smoothly and confidently insert the needle with the bevel up. The bevel should appear smooth and free of nicks. Line the needle up with the vein with the bevel of the needle facing up and pointing in the same direction as the venous flow. Warn the patient by saying something like, "There's going to be a poke now." Insert the needle into the skin at a 15 to 30 degree angle. Sometimes when you enter the vein, you can feel a slight give or a decrease in resistance, or a pop as we like to describe it. C. Steady or anchor the blood drawing apparatus on the patient's arm to ensure that there's no or minimal needle movement. Withdrawing the needle. First, release the tourniquet, then disengage the evacuated tube from the needle. Place a strip of gauze or cotton ball directly over the needle without pressing down onto the needle and venipuncture site. Withdraw the needle in one smooth motion and immediately apply pressure to the wound for 3 to 5 minutes or until bleeding has stopped. It is acceptable to have the patient apply this pressure if they are able to. Lastly, do not bend the arm, keep it extended or raised. Failure to withdraw blood. So the main reason you'll not draw blood from a patient is the tube is not seated or the vacuum has been lost. Number 2, it's about needle position. The needle is either too deep, the needle is not deep enough, needle bevel is against the vein wall, or the needle has slipped beside the vein. Number 3, you have a collapsed vein. The vacuum draw was too much for the vein and it has collapsed the vessel. Accidental needle stick. So if this occurs, remain calm, complete the task at hand. Cleanse the wound immediately. Follow your site protocol for needle stick. And number 4, notify your supervisor. Lastly, complete an incident report form. So the armamentarium most commonly used for venipuncture is a tourniquet, a needle, a needle holder or butterfly, alcohol with or without the recommended 2% chlorhexidine, disinfectant gauze, Vacutainer bottles, a Band-Aid, a Ziploc bag, and a centrifuge. So in our office, we usually have all of these things in a Ziploc bag, just because I'll say to my staff, well, we're going to do platelet-rich fibrin for this patient. They'll go grab this little kit, and most of the time we draw 2 bottles of blood for the formation of PRF. So inside this bag, what do we have? We usually have these prefabricated alcohol pads or alcohol prep pads or alcohol disinfectants. Usually I keep 2, one for the right arm. If you miss on the right arm, you go to the left arm. We also have a disposable tourniquet, a needle holder, then of course you need the needle, and then we also sometimes will recommend the use of a butterfly. We don't usually keep these in our kits, but we will describe the technique for using a butterfly needle for the harvesting of blood for the production of platelet-rich fibrin as well. This is a photograph of this technique being used. And then we have the 2 red glass tube Vacutainer bottles. These are 10 milliliters. Then we have some bandages, which you can buy from Band-Aid, or if you want to support your local dental supply company, they usually sell them too. I like the fabric ones myself. This is a photograph demonstrating the blood actually collected and in the 10 mil glass red tube top. When you put them in the centrifuge, remember that you want to put them apart from one another to weight balance the centrifuge. So you usually spin this at around 3,000 RPM for 10 minutes. And after 10 minutes, this is what you have. You have your packed red cells at the bottom. You have your platelet-rich fibrin clot, and above that, you have your platelet, or your fibrin, or what's it called, platelet poor plasma on the top. We also have these kidney basins, which we sterilize with gauze inside them for the production of our PRF membranes. I don't use a PRF box. So what we usually do is take the snot clots or the little platelet-rich fibrin clots out, put them onto a sterile piece of gauze, and put another piece of gauze on top of them. This photograph here basically just demonstrates the whole technique. So the order of the draw. So usually if you're going to draw blood for patients for multiple purposes. Usually the way it goes is like this. Number one, you'll draw a blood culture specimen. Then you will take your coagulation tube, the blue top. Then number three is the plain red and or serum separator tube. Then your heparin tube. Then the plain sodium heparin. Then the plain lithium heparin. Then the lithium heparin gel. Then the EDTA tube. Then the fluoride tube. Then any other miscellaneous tubes. And then lastly, your heavy metal dark tube top and the ACD yellow top. For our purposes, we're going to be drawing the red tube top, but just FYI, if you're asking someone else or just for your own knowledge, this is how they usually draw them. Diligence. Each step of the process affects the quality of the specimen, and thus it's important for preventing lab error, patient injury, and even death. Jostling and jarring of test tubes in transit can lyse and break open red cells, causing false lab results. Clerical errors in completing forms and identifying patients are common, costly, and preventable. Other adverse effects for patients are common. They include bruising at the site of puncture, fainting, nerve damage, and hematomas. So let's watch now the video that goes along with this presentation. We're going to show two videos. The first video is going to basically demonstrate the collection of blood using the standard Vacutainer needle holder and needle as one piece. The second video describes sort of how to use the butterfly tops.
So in this video, you can see we're taking the kit apart. These are pre-assembled kits that we usually keep in our office, and namely they have inside the bag you have the tourniquet, the alcohol, the vacutainer holder, the vacutainer holder needle, which I'm assembling on right now, and there's 2 vacutainers that we keep inside these kits along with a bandage, and we're usually just opening the package up and getting the bandage ready. Normally in these sorts of circumstances, as you'll see inside the video, I usually grab the tourniquet, the vacutainers, the alcohol, and the needle and vacutainer holder apparatus. My assistant will normally hand me the other stuff that I require. In this case, you can see I'm not wearing gloves. Now, this is not recommended as per the lecture that we've provided here. It is important to wear gloves. However, I was trained initially not to wear gloves, as it's easier to find your vessels, and there's also some studies that would indicate that you're more likely to needle stick yourself when you have gloves on as compared to when you don't. It has something to do with proprioception. However, I would advocate for the novice that when you are doing this, that the best practice is to wear gloves when doing this. So you can also see now I'm grabbing the alcohol desanitizer and just cleansing the skin for this patient, waiting a period of time, allowing the skin to dry, and basically feeling for that blood vessel. An old school nurse once told me that you should go to get the vessel that you can feel, not the vessel you can see. I now have attached the vacutainer to the vacutainer holder, holding the other extra bottle. A small pinch for the patient here. Engage the bottle, which has a vacuum once the needle goes into the skin, and you'll see that we can start drawing some blood right away. And there we go. Usually I like to have the vacutainers facing towards me so you can see the blood filling into the vacutainer tube. In the next video, we're going to demonstrate how to do this using a butterfly apparatus. The main difference between the butterfly and using the vacutainer holder is that it's in terms of stability with respect to the needle vacutainer apparatus. You can put the butterfly in and just tape it down, and basically still pop bottles in and out of the vacutainer holder in order to get blood. In this sort of a case, which I find a lot easier, you have to keep a steady hand with that needle and vacutainer holder apparatus, and you'll see us pop another bottle in here, and there you go. Once again, we're getting a nice draw. So this is the second video for Venipuncture, and this second video, you can see I'm wearing gloves. Checklist. Once again, so after obtaining your samples, you want to make sure that bleeding has stopped to fill up. Patient has a as we previously noticed here, you want to ensure it has a piece of gauze to apply to the area. Many times when we give the needle has gone in, taking a Venipuncture sample, normal practices, you will normally take the tourniquet off first, and then apply the gauze and the skin needle in this video. So it's always important to put a bit backwards in terms of applying the gauze and drawing my needle first, and popping the tourniquet off. It is conventional practice to take the second bottles are labeled, and then alcohol, apply the sanitizer, apply pressure with alcohol wipe, take the phlebotomy, secure the needle, using the safety needle reference here that we have. Pop the tourniquet off, my assistant will take over this in terms of presentation. Applying pressure guidelines for the bandage on me. I'm going to take these bottles. There's the main difference between the butterfly and the needle, which is attached to the vacutainer holder, is stability. So you're basically the same sort of lecture for the vessel. More often than not, we'll be using these with the blood samples tourniquet on in the practice of dentistry.